Yeah. Yeah, so over the Red Sea, cities have been launching on us for, I don't know, a year or whatever now. And one of our cruisers mistook one of our own birds, shot him out of the air. Not good. That's a tough spot to be in, man. I would hate to be like the captain of one of those vessels sitting here just watching stuff coming in. And you are seconds away from your ship getting hit. And you gotta figure out what you're gonna do. That's a tough spot. But that's what we signed up for, right? 80 guys sitting there in the Gulf. Not good. All right, what did we cover yesterday? Microcytic anemias. When I take a step back and I see just how bad this is, I know you guys have a policy, right? So, I walked over there, I couldn't even see it. My handwriting is bad enough, right? I had to try to figure out what the hell is what. So the microcytic, what's our MCV? Right? And what's the problem? Is it any better? No. Wasn't that the purple? Is there another one? Probably juicy. I'm not touching that. So micro is the main, right? We said the problem set is. Never mind. We need some juicy markers. So the problem set the hemoglobin, right? And then what's hemoglobin composed of? Heme, which is iron and your protoporphyrin ring. Alright, and then what else? The globulin, right? Your alpha or beta chain. So somewhere in there, if you're dealing with a microcytic anemia, you can figure out where the problem set is. Right? Alright. So this is your patient. First day in clinic, 21-year-old female walks in. No significant medical history, presents with generalized fatigue, exercise intolerance. So you might just get this, right? And when I say that is your corpsman or your medic or your nurse, whoever does that intake, maybe that's all the information they got you. Okay, now this patient is sitting in front of you. In this class, what are you thinking? What problem set are you thinking? Think anemia, right? So again, in this world of these 2 weeks of hematology, you get a patient with generalized fatigue, pallor, whatever, headache, right? These are kind of your anemia symptoms. So you should start thinking some sort of anemia. 21-year-old female, you start thinking some sort of anemia. Real world, generalized fatigue, exercise intolerance, real world, what other problem sets are on your differential? Thyroidism, right? Is there a thyroid problem? What else? Could be electrolytes, what else? Depression, that's a good one. Right, so there's a bunch of things, right, that you have to tease out, but the key is there, you gotta cast a wide net, have a broad differential, right? By now you guys have heard it, right? You're never gonna make a diagnosis you don't think about. But in general, for the next couple of weeks in the hematology world, you get a patient with some shortness of breath, fatigue, whatever, it's probably anemia. Now you gotta figure out what. All right, so real world, what are the questions you wanna ask this patient? Diet. All right, so now let's lock back into kind of, okay, we're thinking a little bit of anemia. Diet's a good one, right? Did they just become a vegan overnight or whatever, right? Did something change? What other type of stuff you want to know? Family history, short. Somebody said what? Pregnant. Every female is pregnant to proven otherwise, right? And they will hurt you. Alright? So, quick story, deployed in the middle of Somalia, downrange, so far off the map, like Google Map can't even identify where the hell I am, right? Bunch of SF dudes doing whatever, yada yada yada. We get a couple of intel, Yahoos come in, one female, right, on this little whatever we're living in, right, with a bunch of dudes. Wakes me up in the middle of the night and goes, belly pain. bent over, right? Vaginal bleeding, the whole 9 yards. I'm like, oh, Jesus Christ. I am effed, right? I don't even have a pregnancy kit to figure out if she's pregnant or not. Why? Because I'm in a bunch of SEAL team. There are no females. They send me this female intel, right? Now she's bleeding out in the middle of the night, so far off the grid, like any medevac I'm gonna get, it's gonna be friggin' hours. What are you worried about? Ectopic pregnancy. Gotta get that off the table. Okay? So I end up having to medevac this female out of there. Right? And my boss is like, are you kidding me? Like, we gotta do what? Break off mission to do what? Right? So now you're on a national mission team and you just took the mission sideways. Right? Ugly. Like, now I'm getting my wife just eaten alive. Right? Turned out she wasn't pregnant, but she had a hemorrhagic cyst that exploded, like nose drop, right? Ended up needing a transfusion, which was bad for her, but good for me, right? Because now I had some credibility, right? Again, everybody pregnant till proven otherwise. They will hurt you. All right, back to our anemia patient. 21-year-old, female, right? Thinking anemia, sure, all right. What's next? You do a physical. On your physical exam, she's a little bit tacky when you listen to her. You got vital signs on this patient when they walked in the door. She's a little bit tachycardic, right? But always, when you get some abnormal vital signs, always question, right? Did that patient just run in because they were late and they took their vital signs so they were artificially high, right? But you get a pretty normal exam, so not too concerning. What do you want to do next? CBC. All right. Here's your CBC. What do you know about that patient? What do you know about that patient? She's she started menstrual cycle at age 16. But what do you know about this patient? She's anemic. Her hemoglobin's low, her hematocrit's low. So I have an anemic patient in front of me. What else might you want to know? MCV, right? So here, you got your hemoglobin, your crit, you've established she's anemic, right? What type of anemia did we talk about yesterday? How are you going to determine the size? MCV, so you take a look at your MCV, figure out what type of anemia am I dealing with? Right? Start putting yourself down different pathways. That's how you're going to solve these problem sets. Right? All right, I got my hemoglobin, my crit, I know she's anemic. What type of anemia? I'm not sure, but at least at this stage, I take a look at my MCV, and I know it's a microcytic anemia. Right? So now your differential, which was here, is now here. Right? Because now you start going through your causes of microcytic anemia in your brain. What's the cause of microcytic anemia? Iron deficiency. Sideroblastic anemia. Thalassemias, right? So now you're kind of going down that pathway, right? So you got to figure out. So after that, what other labs do you want? Iron studies. Retic potential, right? Plus or minus. I wouldn't have gotten it, probably. But there's your iron. So you're thinking iron deficiency, but your iron comes back normal. Could be a sideroblastic anemia. Maybe. What else? What would you do to confirm any test, anything you want now? Right, you get another test, right? So really for this patient, you go down your differentials, female, and if you start digging into your history a little bit more, maybe a thalassemia. You'll see this a lot because people think they're they get that microcytic hyperchromic, and your automatic go-to is iron deficiency, which is a good thought process, right? Common things being common. So you get your iron studies, do your due diligence, get your iron studies. Prove to yourself it's iron deficiency or not. In this case, the iron comes back normal, so I gotta take a step back, all right? Sideroblastic anemia, you're not gonna see a whole lot of sideroblastic anemia out there, right? Thalassemia, you could, and you will. So thalassemia, all right. So you say, you kind of pinned on, hey, this is thalassemia, what are you gonna do next? Assuming you're going down the thalassemia road. electrophoresis. You got to confirm, right? A confirmatory test, right? But that's how you have to work through a problem set in real life. That's how you're going to need to work through a problem set on the test. Here's your patient presenting with whatever symptoms. Here's a bunch of lab results, right? Can I put that stuff together to come up with a diagnosis, potentially a treatment, right? Any questions?
So I'm kind of not seeing like where my gap is, and I'm hoping that you can help me answer it. Because I looked at those lab results, and I thought it was sideroblastic due to the high serum iron, the high ferritin, and the low TIBC.
I mean, it could be, right? So those results in itself weren't for specific for any disease process, right? I just picked the thalassemia because it was, right? So that would also fit a thalassemia picture potential
Until you do
electrophoresis, right?
Thanks, sir.
So that's the key, right? So you got to know your iron studies, how they correlate with the different disease processes. All right, today, lucky us, we got macrocytic anemia, and then we got to hit the normocytic stuff. Pain. All right, usual objectives. All right, so macrocytic. There we go. There's our anemia chart, right? Start off kind of like that. Hey, are they anemic or not? I look at my CBC, I look at my hemoglobin, I look at my crit. I'm thinking anemia. Got it. Retic count. Sure. But I look at my indices, right? My MCV in particular. It's greater than 100. I know I'm dealing with a macrocytic anemia. Everybody good so far? Yes. All right. So does the peripheral smear relieve hypersegmented neutrophils or macroovalocytes? And as we get deep into this lecture, we'll talk about that a little bit more. And that kind of indicates a megaloblastic anemia, which is your vitamin B12 and your folate deficiencies. All right. So MCV greater than 100, megaloblastic versus non-megaloblastic. Megaloblastic, the problem set here is DNA synthesis. Okay. You need your B12 and your folate for DNA to your cell. I'm deficient in that, I'm dealing with a megaloblastic anemia. On the other column, you see a bunch of causes, and we'll talk about some of the non-megaloblastic stuff. Big ones for non-megaloblastic, we'll talk about like alcohol is notorious for this. Drug-induced is another one, and actually liver problems is another one. All right, here we go. Macrocytic, large, immature red cells. You see the term macrocytes. The other thing you'll see is macroovalocytes. When you see a macroovalocyte, just meaning that the shape of the cell is more oval than it is round. Right? Macroovalocytes. There's your definition, MCV greater than 100. Megaloblastic versus non-megaloblastic. Megaloblastic is a problem with the DNA. Non-megaloblastic, it's not related to DNA, it's something else. Alcohol, drug-induced, some liver issue, yada, 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 right? All right, B12. And there you go, essential for DNA. Essential for myelin formation. Where do we find myelin in our bodies? Nerves, right? So if I don't have this is B12, my myelin formation might not be so good, right? How's that going to manifest itself? Something neurological. Sources, there we go. We talked about this before, like animal products, meat, eggs, dairy. Absorption requires intrinsic factor. What disease process is associated with a problem with intrinsic factor? Pernicious anemia. We'll talk about that. Right? And it's absorbed where? Ileum. Right? Folate, also essential for DNA. There's your sources of folate, your green leafy stuff. And it's absorbed in small intestines. All right. Both require efficient dietary intake and absorption. Right? B12 can take years to develop a deficiency because you store a lot of B12. Folate deficiency will manifest itself early on because your body can only store it so much. a lot of times, even if you went without B12, you can go without B12 for years and no big deal. Folate is gonna show itself in months. Megaloblastic, there it is. Compare DNA synthesis, end up with these large RBC precursors. Vitamin B12 deficiencies, talking about pernicious anemia and intrinsic factor we'll talk about, right? Malabsorption, dietary insufficiency. Again, it's that supply-demand issue here. Malabsorption. There's some there, I'm just not absorbing it, so my body can't utilize it. Folate, dietary, or is there an increased demand issue? Pregnancy. Right, states where you need, they will put all pregnant women on what? Like folic acid, right? An increased demand. All right, clinical presentation. Fatigue, pallor, sure, anemia, right? Glossitis, what's glossitis? Swollen tongue. And then neurological symptoms with B12. Paresthesias, they get numbness, tingling. And again, you know, when you've seen patients real world, you gotta cast a wide net. It's not uncommon to get these patients and complaining of these strange paresthesias. Just numbness, tingling. Right? That should be somewhere in your differential. Folate, looks a lot like B12 without the neurological symptoms. There it is. Your anemia, got it. It's large, macrophagocytes, and hypersegmented neutrophils. When we say hypersegmented, you guys have a picture in your mind of what that looks like. All right, that multi-lobe nucleus in the WBC. Again, that nucleus, right, affecting the DNA. Specific test, yep, sure. I got a vitamin B12 deficiency, my vitamin B12 is low, makes sense. I got a folate deficiency, my folate's low. Methylmalonic acid, you see that in B12 only compared to homeocysteine, which gets elevated in both. And we'll go through the pathways to how that happens. Right. You got to start figuring out how are you going to differentiate one disease process from another. Because again, B12 and folate look a lot alike. All right, so B12, the cobalamines. Nothing new there. Essential for DNA synthesis. Got it. Myelin formation. That's why you end up with the neurological symptoms with B12. And how do you get there? Absorption of B12, right? So hydrochloric acid in the stomach, pure pepsin. Pepsin cleaves it, right? Gastric parietal cells produces the intrinsic factor. The B12 binds to the intrinsic factor, and that allows for absorption. So issues that could lead to deficiency, decreased intrinsic factor. Right? Even if I'm getting enough B12, right, I'm consuming enough in my diet, if I have an issue with intrinsic factor, then I can't absorb it. And the same with this malabsorption, right? Kind of similar theory. It might be there, but for whatever reason, I can't absorb it. And then the obvious stuff, right? Just that, I'm not taking it enough. Again, there you can see, right? It can take up to 3 years for it to develop. Alcoholism, all those issues there. A lot of times these just poor nutritional status you see to those patient populations. Metformin, what's metformin used for? And nobody has diabetes in this country, right? We got people on metformin for years and years and years and years and years. PPIs, like we used to hand that stuff out like candy, right? You got a little upset stomach, you got some GERD, here, go take your PPIs, right? Same with the H2 blockers. You need some Zantac, here's some Zantac, sure. Right? Again, right, go back to in the back of your brain, always think no medication is benign, right? Anytime you're prescribing something to somebody, there's some potential side effects there. Just think about that. Be deliberate when you're prescribing this. B12. No surprises here, right? Fatigue, weakness, shortness of breath, paresthesias, glossitis. Yeah. Sure, all the usual stuff. Your anemia patterns. Lab findings. You know all this. It's a macrocytic anemia, so you know what to expect on your CBC. Peripheral smear, macrovalocytes, hypersegmented neutrophils. I got a B12 problem, so yep, my B12 is low. And we'll talk about Anemia and homeocysteine. Yep, there are your hypersegmented neutrophils. Normal RBC size, that large macrocytic. Right, so significantly larger, and you can think about the sizes, right? So normal RBC 80 to 100. These are usually, you'll see, again, above 100 is the cutoff, but 110, 112, not uncommon. The bone marrow, megaloblastic changes, hypersegmented neutrophil. So associate hypersegmented neutrophil with a megaloblastic anemia. All right, some biochemistry stuff that you guys all love, right? Everybody's gonna tattoo this to the back of their hand now. No. All right. So this methylfolic acid here, right? That tetra, whatever, hydrofolic acid. That's what you absorb into your system. As part of that pathway, if you follow that up to the purines and the thymines, DNA. So I have a problem with this. If I'm not getting this, yep, I'm gonna have a problem with DNA. Kind of similar here, right? But you follow the pathway going to the right. So what happens is, in order for this to get into the cell for DNA, it has to lose the methyl group, right? It loses that methyl group. And to lose that methyl group, it loses it actually to B12, right? And then for B12 to get into the DNA, it has to lose the methyl group, and it loses it to homeocysteine, which produces your methylthionine. So that's kind of the pathway there. And this is why, and you see it better on the other side actually, but if I lack folic acid or I lack B12, I end up with increased homeocysteine. If you just take a look at the pathway down here, if I lack B12, right, then I don't convert the MMA. And that's why you'll get an increase with methylmalonic acid. And that's your differentiation on your labs between the two. But again, here, pathway leads to DNA. Here, the pathway also leads to myelin. And with B12, you end up with your neurological symptoms. Right? So there it is. If I don't have my folate, I'm stuck here with the homeocysteine. I never convert. So my homeocysteine is elevated. If I don't have B12, I can't convert homeocysteine to methylthionine. My homeocysteine is elevated. If I just look at the right, if I can't convert this pathway here, I'm stuck with the methylmalonic acid. And that's only along the B12 pathway. Everybody kind of kosher on that? Ish? All right. So again, B12 plays a role in conversion of homeocysteine and methylmalonic acid. Folate only the homeocysteine pathway. There's your slide, right, in a nutshell. I'm dealing with anemia, so my crit is high or low? Low, it's anemia, right? I'm dealing with a megaloblastic anemia, so my MCV is high. I have a B12 deficiency, so therefore my B12 is low, right? Simple. You guys got it. In this case, folate normal. MMA, dealing with B12, right? MMA is elevated. Homeocysteine is what? Elevated. All right. I lack B12. What do you know? We're gonna try something new. We're gonna give you B12. All right? Fairly straightforward. Start them on B12. Key though, with any of these processes, same with iron deficiency anemia, right? You want to know what the cause is. Just don't want to, hey, go take your iron and you're gonna be on iron for the rest of your life, and we're never gonna investigate why you're on iron. You need to investigate. B12, similar. What's the problem set here? You see the prognosis is good, however, right? If there's a delay in diagnosis, is this person stuck with neurological problems for the rest of their life? Right? And a delay in diagnosis, 6 months is not a real long time necessarily, right? All right. Pernicious anemia. I'll talk about this now. So again, leads to B12, right, deficiencies. So pernicious anemia, autoimmune condition, right? So your body's attacking the parietal cells. You see somewhere that it may attack the intrinsic factor directly. But at the end of the day, right, it's not producing enough intrinsic factor, or your body's destroying the intrinsic factor. If I don't have intrinsic factor to bind to the B12, the body can't absorb the B12. Problems that with the pernicious anemia is the intrinsic factor. Clinical symptoms, similar to B12, got it. Often more pronounced neurological problems. Right? So ultimately here, you're dealing with a B12 deficiency. So your lab results should reflect that. So yes, I have a microcytic anemia. I don't have any intrinsic factor, so I can't absorb my B12, so my B12 is low. Right? Again, when I'm dealing with a low B12, my homeocysteine and my MMA elevated, right? This is essentially a B12 problem set.
So I know, with hypothyroidism, you've got the autoimmune, version, you have like your anti-thyroglobulin, like your anti-TB and your anti-TCO. Is it a similar idea here that if you, to rule out pernicious anemia, that you would request like a certain?
Yes. So there are antibodies that you can order to see if you have antibodies to the intrinsic factor. There's assays you can order that you would end up ordering. So management, right? Again, B12 problem, you're gonna give them B12, but are you gonna give them oral B12? Why not?
Because they
Can't absorb it. Right? So those people end up with shots. There's your anti-intrinsic factor antibodies, right? So a patient like that, right? So hey, came back with a B12 deficiency. You being the smart PA that you are, all right, there's your B12. You bring them back a couple months down the road, check them again, and what? Your B12 hasn't gone up, it hasn't budged. So me being the guy I am, hating people and distrusting them, I'm like, you're not taking your B12. And then they start looking at me like I'm crazy. I'm saying, here's your lab results. Your B12 hasn't budged. I've been giving you these B12 tablets and it hasn't budged. Don't tell me that you're taking them. I'm like, no, I'm taking them. And me being belligerent and accusatory, I'm like, man, you're lying to me. Right? But maybe they're not. Right? Because maybe what they have is this problem, pernicious anemia. They're taking it, they just can't absorb it. So now that should clue you in that, hey, something else is going on. Let me get my anti-intrinsic factor, and you run this assay to see if that's the problem set. Okay. Patients without obvious causes of B12 deficiency, right? So you don't know what the deal is. Why are they not responding to my treatment? Yeah, sure. So pretty quickly, right? If you get them on the B12, right, hypersignature will disappear in a couple weeks. Again, though, if you're delayed in diagnosing a B12 issue, is this patient stuck with a neurological problem for the rest of their life? All right, and then there's the whole intrinsic factor, parietal cells, sure, and then getting absorbed. Good to go. All right, any questions on B12 or pernicious anemia?
Does pernicious usually manifest like in childhood, or does it manifest anytime?
It could manifest anytime. Yeah, and that's the thing with these autoimmune conditions, right? You could be just trucking along one day and whatever kicks it off, and now whammo, it kicks in. Right? And I always keep this in the back of your mind too. Anytime you see anybody with an autoimmune condition, like these things travel together, right? If they got one problem set, there might be another one behind it. All right, moving on to folate. Again, megaloblastic. megaloblastic because it affects what? DNA, right? Alright. Folate, fruits, yep, got it. And do I cook like I do and destroy all the vitamins in my food because I cook everything to death, alright? Alright, total body stores, 2 to 3 months. Again, folate deficiency usually manifests long before a B12 deficiency. There it is. Inadequate, or is there an increase needed? So, yep, is there a diet issue? Is there a GI issue that's affecting absorption? Or is it a body state where a metabolic state where I need more? Pregnancies, growth, there you go. Chronic hemolytic anemias, where I'm rapidly destroying cells, so I need more folate. And then other causes, alright? Oral contraceptives, nobody takes those, right? There's your metformin, antibiotics, HIV, PPI, so fairly common meds, right, can cause problem sets here. What are our symptoms? It's anemia. Right. Again, B12 looks a lot like folate, minus your neurologic symptoms. All right, labs. You guys know this. I'm boring you to death because it's macrocytic, right? Obviously, your folate level is low. Your homeocysteine levels are what? And your MMA are what? Normal, right? That differentiates it from your B12. All right, identify your cause and put them on some folic acid. Bring them back in a couple months and see if their numbers above. Really straightforward. Any questions on folate, vitamin B12? All right, there you go. There's your chart. Yes, your crit is low. They're anemic. It's macrocytic. Your MCV is high. In this case, your B12 is normal, and your folate's the one that's jacked up, right? Again, follow through to look at your MMA and your homeocysteine if there's any doubt. Combined. Yes, some people are devious. Some people have both. Right? Don't trust people. Right? Again, if there's a nutritional problem, a lot of times they go together. Their diets change, so they're not taking in whatever. So clinical manifestations, right? Obviously, they're not gonna, it's gonna look the same. Your lab results. And what are you gonna do to treat it? You're gonna replace the deficient vitamins, right? Easy. Combine, you can kind of see, right? It can manifest itself in a lot of different ways. Ways that we don't often think about necessarily. Right? You know the hematologic stuff, but is it leading to a CHF? Are they having derm issues? Is that how it's manifesting itself? Is this part of somebody's fertility workup? Let's see. And there is your labs, right? So in the mixed picture, your homeocysteine is elevated and your MMA, right, from the B12. Simple enough. MCV 110 to 115, right? So fairly large cells. All right, switching gears. Any questions on the megaloblastic? Easy day, got it. All right, so hey, moving over to the other side, right? So again, still macrocytic, so still greater than 100. It's no longer a DNA problem set. Something else is kicking off these cells and causing them to be large. Non-megaloblastic, right? Something other than DNA synthesis. Liver, hypothyroidism, meds. Oh, got it. So hey, I get this CBC back. I got a macrocytic anemia. First thing on my mind is what? You got a macrocytic anemia. What do you got to take off the table? B12 and folate. Right away, I just got to make sure it's not one of those two. Once I know it's not that, then I can start figuring out what the next problem set is. Right? Anemia and all this stuff, right? Again, alcohol is probably the most common out of all of these. Liver disease, not far behind, right? And then just drugs. but any of that can kick it off. Yeah, and there's your laundry list of stuff. Right, alcohol, we said, chemo, sure, methotrexate, more meds, macrobid. Anybody ever prescribed macrobid? Sorry. All right. So again, right, common stuff: antacids, metformin, macrobid, phenytoin, H2 receptors, erythromycin. Like this is stuff we dole out like candies. Presentation just depending on the cause, right? Is this an alcoholic patient? Is this a person with a liver disease? What's the problem set? And that'll kind of help you. Again, B12 folate normal, management, treat the underlying cause. If they had a thyroid problem that's causing this, then if I treat their thyroid, it'll get better. Right? If it's an alcohol abuse issue, if I can get him to quit drinking, right, maybe that'll treat the issue. There it is. So non-megaloblastic anemia. Your CRIT, your MCV, you know, it's not B12 or folate, so those are normal, right? And then that's not gonna touch your homeocysteine or your MMA, so that's a completely different pathway. Any questions?
Sir,
All right,
what was with the reticulocytosis?
yeah,
The increase in reticulocytes?
right. You can get any of the anemias, right? Potentially there's a body's response, the body tries to compensate, so it starts kicking out more cells. And some of the times too, dependent if they get the cell, and I won't get too deep into this, but sometimes this can lead to pancytopenia, where what happens is the abnormal cells, the body identifies them, right? So the screen is like, hey, these cells are large and look weird, I'm gonna take them out of circulation, right? And they start taking that out. And especially for the megaloblastic too, you'll see it more there. Because the DNA problem set there doesn't just affect the RBCs, it affects all the other cell lines. Macrocytic, 70-year-old, fatigue, neuropathy. In your mindset now, right? Fatigue in this class leads to anemia, right? Neuropathy, they got some nerve symptoms there. So you right there, you should be like halfway home already. Your hemoglobin's low, your MCV is high, so you know the patient's what? Macrocytic anemia, right? Boom. You do your B12 levels. Uh-oh. All right, anybody know normal B12 levels? Yeah, that's low, but it's like somewhere between, like, it's this huge gap. It's like 190 to like 900, right? It's a ridiculous number, right? So that's low. But you knew that was low. Why did you know that was low just reading this? Right. They got neurological symptoms, right? All right. So again, differentiate. Think of how you're going to separate a B12 from a folate. Any questions on that? Everybody solid? All right, take 10, come back, and then we got the long lecture of normocytic anemias. So the CDC, they always get a CD. You get it in the CD. Right? Just from this, I found it.
Wait, I was trying to read.
Can you just say?
I'm like, that's a difference. Both parents had to like figure out stuff and what's that's just weird. Like I'm not even there yet, and I feel like most people my age don't have to think about that yet. Because like my parents and like his mother are like 50s or 60s. She ended up where he ended up with hospice. He's fine. Just like he's at this point